she appointed before to invite you to complete the feedback form. I'd also like to let you know that the seminar is video recorded. I hope that's all right with you. We're not edited. And the recording list can be accessed by Marriage PRA Department's website. Finally, as many of you may know, for those who are able to stay on after the seminar, we provide refreshments at the foyer. So now it's my great pleasure to introduce Miriam. Miriam is a professor of compassionate care of York Medical School. She's also an honorary consultant, has a position at Scarborough General Hospital and St. Hospice in Scarborough, where she is one of the first palliative care services for people with heart failure. Now, Miriam will present research not on heart failure. She will be presenting on chronic breathlessness, including the naming of the children. So I'll hand over to Miriam, and she'll present for about 40 to 45 minutes, leaving us for about 15 minutes for questions.
Right, lovely to be here, and well done to all of you who, like me, have completed our Sherlock Holmes task of the day, which is, where the heck is this lecture theatre? I think I've been to most buildings up and down this little road, but I feel quite smug and bloaty that we got here, really, so we can share that feeling. Now, today, I'm deliberately not spending a lot of time on the management of chronic breathlessness. Not because I don't find it fascinating, but every now and again I feel like a stuck record. However, I'm very happy to discuss that afterwards in questions if people have a particular point or thought they want to air in the group. I'm very happy to do this. But today, I want us to take a step back first and take the bird's eye view. First of all, how does breathlessness affect us as a population around the world? And I'm going to present work that my colleague David Curran and I have done, scouring various data sets, both the UK and abroad. It's one of our little hobbies, and we've decided we need to get out a little bit more, because there's nothing more than we love than the ping of a nice big data set arriving in the inbox once you've got through all the data sharing agreements and dearie me. Because I think we can learn a lot about how important a topic is by taking that bird's eye view, by getting that high level idea of just what an impact this has at the population level. Because that is what informs very strongly policies, services. And then I'm going to say exactly the same thing about listening to the individual. Because when all is said and done, wave a hand if you're a clinician in the room. The thing that, we love, don't get me wrong, I'm wedded to evidence-based. My goodness, my entire career is evidence-based, but the things that often stick with you and drive you and give you that still get up to work in the morning are those individuals where you know you've made a difference and where you've been touched by their individual experiences. And I think I want to get across to you the voices of individuals who are living with this invisible thing every day. And I want to let their voices speak. And then I'm going to just come back and have a little bit of a think in terms of, well, very quickly, what does that mean for us? So just to highlight some images as we go through, is there a little pointer doodle thing? Oh, finger will do. So, lovely image on the right, some fantastic work that one of our postdoc researchers, Anne Hutchinson, has been doing. She helps run a people with experience group, so people who are living with chronic breathlessness and their families. She helps them with a support group, and she managed to get them to engage with some artists, and they had this amazing workshop where the people who knew what it felt like tried to put into words and explain to these artists what it felt like, and then the artist translated it into a visual impact to try and get that message across to people who don't know that experience. This is what it's like. So this is just one of them with the stairs. I just think some of these people are so clever at visually getting across a message that brings the gut through and totally overtakes the head and helps us suddenly get why this is so important. So, populations, prevalences and associations, and then persons living with chronic breathlessness, and then something around living well with chronic breathlessness, and then a little bit about so what. Oh, can I, and I do mumble, I'm terribly sorry. Can you hear me at the back? No. Okay, we better mic. While they're micing me up, in this case, shall I just sort of bawl and shout a bit? Would that be... Oh, no, here we are. How about that? I have to press it. Well, it's great. Like that? Yeah. Like that? No, that's red. I think it's got to go green. Maybe it should be. That's a green one. Oh, is that? Aha. That's no. Maybe they're not charged. It's only flashing green intermittent. I tell you what, I shall project. Is that all right? It's not going green. It's every now and again doing a bit of a pathetic red. So can you just wave at me if my voice drops a bit? And I shan't take it personally. As I said, my mother always used to go on to me, I don't see how any patient hears a word you say, you mumble. So, Up Mother's great, you know, just as you think you're starting to be somebody, they kind of bring you back to earth, don't they? Right, so here we go. Chronic breathlessness. Ladies and gentlemen, I want to convey to you just how important this is and how common this is. In the population of South Australia, and I really don't think they're that different to us, 1 in every 100 of the general adult population has chronic restricting breathlessness, as defined by stops for breath by 100 metres or after a few minutes or worse. And I'm calling it chronic because it specifically asked for people who were experiencing this over a matter of months. Other studies that you will find will show that the prevalence goes up between 1 in 3 and 1 in 4 of older people. Now, those studies don't necessarily pinpoint chronic breathlessness, but I still think, you know, it's very likely that these are the people who are living with breathlessness as a daily event. So between 1 in 3, next time you walk along the street, take a little trip down Euston Road and do a bit of an age guess on people and think, you've got a 1 in 3, 1 in 4 chance of being breathless. Shall I ask you? Because otherwise we don't see, we don't know. That person who stopped to look in the shop window, maybe that's one of the ways they can still get out the house. Now, here we go. Now, let's think about another common issue within which there's a common issue. So we have an obesity crisis coming over from the States now hitting the UK. And look at the relationship between breathlessness and BMI. And isn't that really, really important? Because breathlessness is intimately woven up with physical exertion. So if we want to do something at the population level about our obesity crisis, we need to be getting people to move more, as well as eat less. And if we want them to move more, the very people we want them to move a lot more, they are the people who are really suffering with breathlessness. So you can see how this becomes a decreasing spiral, that the more breathless you are, the more likely you are to avoid the things that made you breathless, and you do less and less and less and less. We need people to do more and more and more and more to maintain a healthy body weight. And the thing about this, these data, so again, these are data from South Australia. What I found interesting is that you have a sort of a cut point at the severely, morbidly obese in terms of severe breathlessness. So if you look at, I keep thinking that thing there is something I'm going to fall over. I have nearly fallen off a podium before speaking, so I don't want to do that again. So here, it's almost like the a little bit breathless stays more or less the same, but the minute you slip into morbid obesity, your severe breathlessness really takes off. We've also got a U-shaped relationship with body weight. So these are data we got from the US older persons longitudinal study. So these were people 55 and over, followed up over a number of years. And looking at the baseline data, you can see this clear relationship between breathlessness and body weight. And once you're underweight, and we know from it, from experience, it's very likely to be related to not just loss of fat, but of loss of muscle, you can start to see this makes sense. That you lose muscle, you become breathless for any given, more breathless for any given amount of work. So I hope I've got you interested with that. The other thing, while we're talking about breathlessness and body mass, what about the patients coming to pulmonary rehab? Do we think in terms about their body mass? Do we think that the people who are either underweight or overweight might just need that little extra bit of support and encouragement to move and do their exercise? Does it even impinge on us that these people might be those who are going to suffer worse with breathlessness? And I don't know about you, but many of the patients I deal with have got this misconception that breathlessness itself is damaging. And I can understand entirely why they do that, because it's blimmin' horrible. So you refer someone to pulmonary rehab and they go, you want me to do what? I've just spent the last 6 months not doing any of that because that's the only way I'm comfortable. So we have to deal with something. We can't just send a letter of referral to pulmonary rehab. We have to do something around this. What does this mean for this individual? And so I'd like to put another thing in your thinking caps to really make you think about the person's body weight as well, because that complicates it. So, we also know, this is another data set that we worked on. This is an extraordinary data set of people from America, older adults aged 70, so they recruited this massive cohort aged 70. They had the most extensive review with examination every 18 months, and every month they filled in this enormous questionnaire, and the data completion was incredible. I'm thinking you wouldn't get a bunch of Brits doing that, oh no. But it gave us this wonderful data set. And so we looked at, we had a follow back, so this is the point of death here on the right side, and then we looked back during the months before death at the frequency of reported restricting breathlessness. And you can see it doesn't matter what they died from, breathlessness was starting to be more of a problem in those last few months prior to life. Now, it's not, we expect it for the cancer patients. We expect it for the organ failures. The dementia was a bit of a surprise to me, but I thought, well, no, maybe they're losing their swallow, maybe they're getting some aspiration, maybe they're getting muscle loss. Frailty, I didn't expect that to start with, but then I thought, well, again, muscle loss, perhaps less well, clearing respiratory secretions, kind of making sense. But then what about the sudden? So deaths thought to be sudden. They too have got some increasing breathlessness in the months prior to death. And again, you then think, well, actually there are the literature about the young cardiac deaths, which are supposed to be sudden, but then you take the history, and well, actually they did have a funny do 2 weeks ago, and they were a bit breathless a few weeks ago, and then they had that bit of funny palpitation. It's not, you can sometimes get that prior history. So what do I take from this data, these data? Do you know, can't believe I said that. Any of my PhD students will say, my mantra is, data are plural. Every comment box through everything they write. So don't tell them I said this data. I'll be so embarrassed. Shh, our secret. So what do I take from this slide? I take that actually breathlessness has to be taken really seriously. And if people start to report to you that they are feeling breathless, perhaps this is the sign of something serious, and perhaps some of this worsening breathlessness might have been reversible. How many pulmonary emboli were there? How many decompensated heart failures were there? How many subclinical, or poor, or won't be subclinical, just didn't get picked up properly, exacerbations of COPD were there? And a lot of the time we stop listening about breathlessness because we've got our diagnosis. In fact, we stop listening before we find out that they've actually got 2 or 3 diagnoses, actually. We stop listening when we think we've ticked the optimum treatment. We must not stop listening, because breathlessness signals something which is important to the patient and might need management. So again, let's just look at let's bring the microscope into the last 3 weeks of life. Now, these are clinical data from a hospice service in the west of Scotland, so they cover all settings, and every single point of clinical contact, they take patient report measures. So these are from 48,000 and over observations, real live clinical time reports And we looked at breathlessness intensity, and we looked at people who, according to Karnofsky performance status. So we roughly divided it into those with 40 and above and those less than 40. So reasonable NIC for palliative care and poor NIC for palliative care, even for palliative care, roughly. Okay? Now, this is where I really could do with a pointer. So let me go through this. If people died with cancer, so these are our first two left columns, the white ones are people who are really poorly. So they're in bed or chair most of the time. These are sick people with a poor prognosis. But yet you can see that the breathlessness level increases a little bit as they get nearer to death. If you take the people who are more ambulant, the breathlessness level is worse. Well, that makes sense, doesn't it? Because they're doing more. Breathlessness is intimately tied up with physical exertion. And again, you get that last blip in that last week. But look at the people dying from cardiorespiratory disease, remembering they are, although they are inflammatory, they're probably not quite as inflammatory as very end-stage cancer. If you look at people with very poor physical function, their breathlessness level just stays pretty much flat lines in the last 3 weeks of life. But look at the people who are actually more ambulant. Their breathlessness level is worse, and in that last week of life there's this big something's happened. So what does that tell me? What tells me is that this lot on the right might have had something where they weren't quite ready to die yet. They were still pottering about. Has that breathlessness something shortened their trajectory? I asked the question. I can't give you the answers to that, but again it brings me back to the point we must listen to our patients, and if they flag up that they're breathless, we do not let that drop to the carpet to be ignored. We pick it up and we assess it, and we make the decision, is this something that needs to be managed? Is there something that's going on? And this is similar data, just looking over the last, as the whole group rather than broken down by performance status. And in the last day, so the last week, so right coming out of the last week, people with respiratory failure, it does, if anything, it gets a little bit better in the last 2 or 3 days because you're not doing anything. These people are so weak, they're now dying, they're doing very little physical exertion. And actually that's quite a reassuring thing to say to our patients. Again, I'm sure you have the patient in clinic and I say, what is the one thing you're really worried about? I'm going to suffocate to death. Well, here we have data to say, well, you know, we can't predict the unpredictable. I've just shown you a slide before where things can get worse in the last week. But as you get weaker and weaker and you move less and less, your requirements for breathing will also come down and it may become more comfortable. But obviously, if it is bad, we can do X, Y, Z. The rest is a slow, inexorable climb, getting worse in the last 7 days. So I hope I've got the message across to you that this is really important. But yet it's really only the last 20 years, really, that we've got serious about breathlessness research. So why else do I think breathlessness is incredibly important? Well, let's have a look at people with COPD. The FEV1 is not a good predictor of survival as subjective measure of breathlessness. Now that shouldn't surprise us because what might be going on here, again, we can have 2 patients coming to clinic. Patient number 1 has an FEV, let's call it a percentage predicted of something horrid like 15%. They are still getting to the shops, they're still taking part in family, they're helping with the grandchildren, they're reading books, they're getting to the club. You know, we know that these people have found a way of dealing with their breathlessness. The next patient comes in, exactly the same FEV1, and their life has stopped. Because the different ways of dealing with breathlessness is such a complex thing. It's not just a particular peripheral sensory input. It's the whole lot, and what's going up from here, and their cognition, and their personality, and their family support, and their socioeconomic status. So it shouldn't surprise us that this is the case. And it also should spur us on to help patients manage their breathlessness better, because we should be able to help them live better with it. So again, coming back to the longitudinal American data set that we had, again, this shows the same thing, that breathlessness, measures of breathlessness discriminated in terms of survival. So you can see that blue line often became short of breath, they're dying quicker. But looking at the same data set, so let's just go back to that one. So that's within the first few months of baseline, you're starting to see a difference. But for those who survive, by about a couple of years, if they haven't died, you're starting to get a big difference in how well they are able to do their activities of daily living. So we're now getting into health expectancy, not just life expectancy. And there's a big difference, isn't there? There's the life expectancy is how long you live till you die, and is your health expectancy, how long do you live with healthy life, and then you're living with ill health until you die. And breathlessness is something which robs years of health. Which brings me on to quality of life. Again, our Australian data set, a barn door relationship between breathlessness and both physical and mental component of quality of life. So the more breathless somebody is, the worse their quality of life. And the minute you say that, you say, well, stands to reason. And my response to that is, well, why aren't we actively seeking this out in our clinical communities and doing something about it? Why do we have this expectation that people will be like this because you've got COPD, because you've got ILD, because you have cancer, because you have bronchiectasis or heart disease? And, this is serious stuff. We looked at the ALSA data set, so longitudinal study of aging in Australia, and looked at factors independently associated with reduction in sexual activity. Breathlessness, not surprising. And again, if you ever are brave enough to ask your patients about what is the impact on their intimate life, they are often amazed anybody has had the sense to see that this might have had a really big difference in turning someone from a wife or a husband into a carer. And that devastating dynamic within that relationship. And not just with people with relationships, the fact that somebody might possibly want to have that as something they might do at some point, or masturbation, or any of these other things that we are so wussy about talking to patients in the clinic. And we're so very British. But once you open that door, if a patient does need to talk about it, oh my goodness, they go away saying, you're the first clinician who has ever bothered to see that that is a sadness in my life. And every time I have the courage to do that, it makes me feel, why don't I do this systematically? And I don't because I find it hard, because I'm wussy and British. So, on to other tricky things. Now, I don't know about you, maybe you're different down in London. Where I come from, I have yet to come across a patient that says, oh, what shall I do this afternoon? I know I'm going to have a lovely afternoon in the emergency department. Oh, no. However, 5% of all presentations to the emergency department are because of breathlessness. And you're more likely to be admitted if you have severe breathlessness. You're more likely to have a serious in-hospital event if you have breathlessness, and you're more likely to stay in hospital longer if you have breathlessness. So your use of health services is going to go up if you get breathless. Now, my wonderful postdoc, Anne Hutchinson, who I sent off to the emergency department to do her PhD survey in Hull Royal Infirmary, which is just like Armageddon, basically. It really is, I have never seen such, I'm sure emergency departments around the country are incredibly stretched. And she went in bless her with this lovely feeling that all she had to do was ask the triaging nurse to hand the survey to the patient at the end of the clinic, and at the end of the whatever the triage nurses do with the patient. And I can see why she thought that was reasonable, because it would involve, thank you very much, here's a survey, would you have a look and fill it in if you like, end on, moving on. That is too much to ask. Believe me, and I understand why, it's too much to ask. So we had to go around a lot of houses, and eventually we managed to employ people, morning, noon, night, round the clock, weekends, to get a truly consecutive sample of people brought to the ED by ambulance. 1 in 3 of those ambulance presenters lived with chronic breathlessness. 1 in 3. And 1 in 5 of those people brought by ambulance had come that day because of breathlessness. Now, those numbers are staggering. And if you think about that impact on those people who do not want to be there, of those family members who do not want this to be happening, and the ambulance services which are also at breaking point, and the emergency departments that are going like a fair, that is a huge impact on our health services. You know, I would put it to you, ladies and gentlemen, even if we did not care about patients one bit, and I hope that's not the case, we cannot afford in this health service to see these figures and do nothing. We have to do something about the management of acute on chronic and of chronic breathlessness. When she asked the patients, who do you talk to about your breathlessness? Look, 75%, 3/4, are talking to their GPs. So straight away you think there is a opportunity for self-management, for breathlessness management review, for dealing with that. How do you deal with breathing like this every day, and how are you going to deal when you have that next crisis? Family and friends. And this really, really poignant and sad, no one, 14%. Isn't that just a tragedy? Who was involved in your decision to present? Only 1 in 3 really, really wanted to come. The rest were shipped there by their family. A few were sent by the GP surgery. An even fewer number sent by, again, I don't know, in Yorkshire we call it the NHS Directory in A&E. Maybe that's a bit cruel. It's the out-of-hours call line, and we're sort of on a bad day we think all they do is say off to A&E. And a paramedic. I have to say paramedics are really waking up to the idea of breathlessness as a reason for call-out, and some of them are really developing good practice. Here's another picture of our patient who was describing a house of horrors, what it's like to live with breathlessness. Now, you'd have heard me mention acute on chronic breathlessness. I state it deliberately, because what tends to happen is the patient rocks up to the ED with their acute on chronic breathlessness. The only bit that gets managed is the acute breathlessness, and they're recycled back to the community, still with the chronic breathlessness, still with that framework within which that crisis happened, with no further idea of how to manage it, with no further idea how to manage the next crisis when it comes. We really, really have to change this, because again, as I say, 1 in 5 being brought by ambulance to the ED. We cannot sustain this as a health service. And as the patient advocate, that is just not where they want to be. So, what can we conclude from our population studies? Number 1, it is common, especially in older adults and especially in those under or overweight. Number 2, it is associated with bad things for the person and services. Earlier death, earlier loss of independence, poorer quality of life, reduced sexual activity, and increased use of unplanned healthcare and longer and more hospitalizations. That is what we are facing. That is the burden of this in our population, with the people that we rub shoulders with day in, day out, perhaps even people that we work with, but we don't know because we don't see it. So, we decided that we should do something about this, so we managed to rope in a very impressive number of very clever people from around the world as part of the Delphi process to get consensus in terms of this should be a named syndrome. Because if it is a named syndrome, we give people something to look for. We give patients the legitimacy to come back to their doctor and say, look, I'm still breathless. It's not just to be expected. It isn't something that doesn't have anything to be done with it. It should be found, it should be sought. It shouldn't just be this impasse where patients don't mention it because they think if there was something the doctor could do, they would ask, and the doctor says, I'm not looking at it because I actually don't think I can do anything, so I'm just not going to see it. And then, to make them feel better, and if it was important, the patient would tell me. Do you see how this kind of invisibility, this block, we've got to break that block down, and I think we have to take responsibility as clinicians to make the first move. It's a little bit like saying sorry, isn't it? I think clinicians need to say sorry first. Sorry, we haven't seen this breathlessness. I now know what I'm looking for, and can I ask you about it? And again, training our colleagues to get beyond asking, are you breathless, to which the patient will probably say no. Especially if they're waiting for my clinic, when I've got yapping, and they've been unconscious in the waiting room, and probably fossilised by the time I get to see them. Of course they're not breathless, they're not doing anything. We need to get beyond that. So what do you do before you get breathless? What have you stopped doing or reduced doing because of breathlessness? How much does it impact on your life? And so this is what we came up with. This is the definition. We then took this to the biannual Dyspnea Society conference that was in Paris that year, and we had the rather terrifying experience of presenting this to 80 experts from around the world who then sort of shot holes in it and ripped it to bits and then put it back together again. And this is what we came up with. So, to my interest, back to prevalence then. So now we're talking about the specific syndrome of chronic breathlessness. So this is breathlessness persisting despite optimum treatment, resulting in disability. So a French group have now done a consecutive cohort on their patients with COPD, and to their horror, they have found 53% of their patients with disabling breathlessness, despite optimum treatment, with little, if any, evidence this was being treated or looked at all. And I take my hat off to them for publishing that, because hanging your dirty washing out in hanging your dirty washing out in public, is not good, is it? But it's not just them. I bet if we did a consecutive cohort of any COPD service anywhere in the world, we would find the same. Again, just love that, that hedge. It's just, used to do this in 10 minutes on a Saturday afternoon, now the hedge just gets higher. So here is a fabulous study. I think that this study design is great. I'm going to nick this. So this was a randomized controlled trial of an online scenario. So respiratory physicians were sent out this scenario, but randomly the patient was to have either breathlessness or pain. And the scenario was of somebody who had optimally treated COPD. So, it's former smoker, check. Triple inhalation therapy, check. Flu, pneumococcus, check. Pulmonary rehab, check. And this was so they either had either severe breathlessness or severe pain. So note, severe, but markedly restricted daily activities. So this isn't just a little bit of I ran for the bus and I had to recover for 2 minutes. Unchanged for 3 months. Those are key things. Severe, restricting, persistent. And the question asked was, does this patient need further treatment? And if so, what type of treatment? Now, hold on to your seats, ladies and gentlemen, because this isn't a pretty sight. On the blue side, it's pitiful. Only 10% thought that this patient might possibly need a bit of extra treatment. And of those, very few thought about opioids as just one of the options. However, I'm also appalled about the pain. Only 30% thought that a patient with severe pain that was markedly restricting daily activities and had been persistent for 3 months didn't need further treatment. I'm too speechless to say anything else about that slide. We don't see it. So, that's enough ranting on at populations. We'll now bring it down to the individual. And with this, I'm largely just going to read out the voice of the people concerned. And these are all data from Anne Hutchinson's systematic literature review and qualitative synthesis of 101 qualitative papers. I told her not to do 101 papers. She insisted, and she did an amazing job, and I'm really glad she did not listen to her supervisor at this point, who just wanted an easy ride. The worst thing, I think, is the stairs. Going up and down the stairs, ordinary household chores, is difficult because of your breathing. And now, even simple things like having a shower or getting dressed. Well, I can walk around 200 yards, then I have to sit down and rest, even on a flat road. You can walk around the shops, but you can't carry anything. I've no time to worry about my physical health. My health's not too good. I'm physically worn out. Anyhow, I try not to think about it so much. One has to put food on the table and take care of the home as well. Must remember the carers. And they feel even more invisible than the patients. Well, then I'll be fine, but I'm all the time worried when this breathing will attack me again. Depression is the biggest problem. It's the worst because if you are an active person all your life and now you're inactive, it's hard to accept. The emotional thing is extremely important. If you don't get the understanding, you can just get caught up in a downward spiral and you end up in this little place all by yourself. And it ain't just me, it's my family as well. I've got 2 boys and my wife, and they have to go through it as well. People tend to forget them. They just think about the person who's got the illness, not the people they've got around them. And it does affect them big time. They get emotional. They're frightened. Well, I've become so depressed just after Christmas that I used to sit down at night just crying. I went to my GP and he gave me some pills and I think they've helped me a bit. Still, I'm sad. Terribly sad. And mentally, I am worn out. The silly things, not being able to carry the shopping. I was brought up in the Victorian school. The man always carries the bags. Personally, I'm really delighted I live in a culture where it's the man job to take out the bins. I could do it, but don't tell anybody. I wouldn't like to take away any of his feeling of manliness. And I can be incredibly grateful and look very dewy-eyed when he's done it. He feels angry about the way breathing limits his life. He's been active all his life and now he can't do anything about it. He describes problems with maintaining an active sex life and is deeply concerned about it. His breathing is affecting all parts of him, not just his lungs. His breathing has been bad enough, but this impotence, he feels not a complete man anymore. When was the last time you had a conversation with your patients about that? It's a hard time, I tell you, and it gets you down. When you think what the nurses do in hospital, giving him his tablets and everything, well, I'm doing 1,000 jobs as well. I'm just going crazy because you don't get to the end of it with nurses, with doctors, with housewives, with cooks, with gardeners. And then, gradually, we've had less and less to talk about. He gives the impression he has no interest anymore, either in myself or in his surroundings. I think this is some kind of envy of me. After he started to go in and out of hospitals, we stopped being good friends like we used to be. The disease has isolated him from his family and myself, and now we have restricted issues to talk about, and it makes me sad when I think about it. I'm really in need of some form of intimate contact with him, but I don't want to press him. And it's something one cannot talk so easily about. I'm afraid he could sense it as an accusation. I always said I'm not afraid of dying, because I know where I'm going, but when I get short of breath, I get scared. I think smothering to death is a hard way to go. I went down to Mass in the car, and my wife said to me, "You shouldn't go down because you're not able to walk that far." And I really couldn't walk from the car park, so I had to come back and get into the car and go home. When the shortness of breath was at its extreme, I thought I was going to die, and I saw a coffin behind me, and then I was in a tunnel, and I did have thoughts about suicide, and I envied the dead. I wanted to end the struggle to breathe. So I want to highlight again, there's a number of things through there that carers said, and I want to draw your attention to some fabulous work that Morag Farquhar has done about carer needs in looking after people with COPD. These are the things that carers want to know. They want to understand about breathlessness. They want to know how to manage anxiety and panic and breathlessness, the exacerbating infections, how to keep active both themselves and for their loved one, how to keep living positively despite this dreadful thing. And they want to know what to expect in the future. And we must encourage our colleagues to have braver conversations with people, especially where there is uncertainty. Uncertainty is so often held up as a reason not to go there yet. Well, I might be wrong. I'm going to worry them about nothing. Surely, if there is uncertainty, there is a possibility that things are not going well, and should we not at least try and warn somebody and to get an idea of how they would like these things to be dealt with if they could not speak for themselves? Uncertainty should be a trigger for a brave conversation, not a barrier for a conversation. So what did Anne do with these 101 qualitative studies? Well, she went beyond the usual describe the themes, which I was very impressed with. And she came up with this concept of how can people live as well as they can with breathlessness, and what happens when they don't. And she came across these three really key things that we must understand. Number one is, how does the patient cope with their breathlessness? Do they engage with finding ways around problems? Do they find ways of dealing with it? Do they keep in touch? Do they maintain their role? Or do they just sit back and say, my life has stopped? I can't do this. Do they stop going to the lawn bowls, or do they stay and keep scorchy? You know, there's two approaches there, isn't there? What about the way they seek help? Are they really good at learning everything they can about self-management, of understanding their disease, of keeping moving, of finding ways to stay in touch, of using their health service team effectively in a timely manner? Or do they ignore it and ignore it and ignore it until something's so bad they have to call the ambulance? And then lastly, and this is where clinicians are really put on the hook. What came through really clearly from the data is that patients who had clinicians who responded to the breathlessness and managed the breathlessness in addition to the management of the underlying disease gained better breathing space than the clinicians who just said, you've got your triple therapy, you've had your flu vaccine, that's my job done, tick. You're bound to be breathless, you have COPD. So breathing space, a useful thing, and I think a useful thing to kind of guide our assessment. Do we understand how these patients are coping? Do we understand their pattern of help seeking? And what response have they had from their clinicians? So what? Well, I think this matters because at the moment it's still invisible for many people. Even when severe, sitting down in a consultation, you may not notice that the patient is breathless. I mean, they might be a little bit out of puff when they sit down in the chair, but it goes very quickly and you can get caught up in the U's and E's and the drug doses, and then you're back on comfortable ground again. There is a normality, there is an expectation that this is just part of the picture. And if we do not actively elicit it, it is likely not to be disclosed. we should measure and assess in every patient as our responsibility, not theirs. It's important because it's manageable. And I'm just putting up here as an aid memoir, Anna Spathis and the Cambridge team's fantastic clinical framework for drawing up a management plan of chronic breathlessness. And I use this every Monday afternoon in my clinic. I have a laminated copy that I use in discussing with patients, and they just get it. They get these vicious cycles that drive the patient, the breathlessness up, and you can drive it back down again by addressing these vicious cycles. And they'll go away from my clinic with a couple of interventions tackling the predominant drivers of this breathlessness cycle, and often with something that tackles each of them. It's an open access paper. You've got the reference there. I really encourage you to go on one of their courses, start seeing about how you use it in your own clinical practice. I had a lovely respiratory interventional pulmonologist from Bangalore in clinic with me on Monday who'd learnt about it just by doing a PubMed search and started to use it in her clinic, in her respiratory clinic in Bangalore. You know, these are almost like universal truths in terms of what patients understand with this. Something which is quite old now, but I think still is a useful frame for thinking about managing people with chronic breathlessness. First, make sure it really is chronic breathlessness. Is the underlying disease treated optimally? And have we got a situation where you have somebody with comorbid lung and heart disease where you have one bit optimally treated and the other one's got forgotten because they're in the wrong clinic? Yeah, we all see, I've got some nodding heads there. Second step, the bedrock for management of breathlessness is non-pharmacological. And a word to the doctors amongst us, wave a hand, own up if you're a doctor. There's a few. Can I say, brothers and sisters, we have to completely and utterly, and all the other words ending in ill-ly that I can think of, endorse non-pharmacological treatments. We must impress on our patients that this is every bit as important as the inhaler, as the drug, as the intervention, because we're not good at doing that. And then we wonder why they don't turn up to pulmonary rehab. We wonder why they don't turn up to the physio. I mean, our physios and our respiratory nurses and our heart failure nurses, these people are incredibly skilled and do an amazing job. And you know what? Even we can use these techniques in our clinic. And I think the thing that really made me laugh recently in clinic, a lovely guy, end-stage heart failure, had been sent for breathlessness management, and we talked through, and his goal was to get back to his club, and we went through a few techniques, and he got back to his club. And he came into clinic, and he said, "Oh, I've been telling everybody in the club what a great doctor you are." And I was thinking, "Oh, good." So he said, "Yes," I said, I've been seeing that Dr. Johnson at the hospital, and I feel so much better, and you know, she's done nothing." So that wasn't so good. But you get my point. There is a mindset, both in the lay public and our patients and the medical community, that the non-pharmacological measures and interventions for chronic breathlessness somehow are nothing. They are not. They make a difference between people getting to the bus stop 200 yards from their front door so they can get into town. They make the difference between somebody getting themselves to the toilet. They make the difference between someone getting their own cup of tea and up the stairs back up to their bedroom again. Non-pharmacological. Education and support for family carers, and make sure all your patients have a crisis plan. Third step, and only at that stage would you consider low-dose sustained-release oral morphine in selected patients with careful review. I've deliberately kept away from management. I'm very happy to answer questions about this afterwards if there's time and anyone's interested. There is further data coming out, and a world first now. Therapeutic Goods Administration in Australia has given Capanol, which is a sustained-release morphine, the first license for chronic breathlessness anywhere in the world. So things are moving a little bit, and I'm happy to take questions on that. So, in summary, chronic breathlessness is... Any of you remember, some of you are old enough to remember the 70s with the Love Is cartoons? They were really sickly, weren't they? Yes. So chronic breathlessness is common across the population. It's associated with bad things for the individual. It's associated with bad things for the carers and bad things for the health service. It is still neglected. Despite this weight and burden of problem, we're still not taking it seriously. There is an awakening with NHS England that are starting to see that a symptom-driven approach might be a really good way of implementing a long-term plan, but I'm waiting to see how that pans out with implementation. It is manageable, and patients can live well with breathlessness. And it is manageable, and there are good clinical models for which are useful in practice. So I leave you with this website, another fantastic image. You can't put that into words, can you? It takes you a long while before you realise there's a woman's face still in there, just if you look hard. There's the website, so you can have a look at the exhibition online. We also have a booklet that you can download and use to your patients called Living Well with Breathlessness, which we've done in conjunction with the Cambridge Breathlessness Intervention Service, using some of their really good tips about recovery position, pacing, prioritising, how to use the handheld fan, some simple breathing techniques, and some stories, patient voices. So very happy for you to go on there, download it, use it in your clinical practice, totally free. Do just let us know if you found it helpful. And then I think I'm just going to shut up now. And thank you so much for your attention.
We've only got about 5 minutes, I think.
Oh, good. Time to perfection, then.
Miriam will be in the foyer if anyone wants to ask further questions.
Yeah, depending how serious your question is, you might want to time whether I'm at the top or the end of the glass of wine, but might vary the answer you get.
And the slides will be available on the top website.
And just a word, please don't lift the images and just send off. We're very happy to share some images, but there's a process to go through, so just let me know.
You mentioned the Euston Road and poor air quality. How significant do you think that is for people living with breathlessness? Just, I've had patients who were living in areas of poor air quality in London who do definitely feel better when they move to Norfolk.
I think that is going to be one of our big public health challenges, and I'm absolutely convinced it plays an important role. And if anyone in the room has actual facts and figures for that, just pipe up. But I'm going from, I'm sure you're right. Oh, hello, nice to see you. Yes.
Thank you, that was absolutely fantastic. I wanted to ask a question about the parallel, which is lots of data about why breathlessness is hitting patients talking about it. What about us as clinicians? And is there starting to be research on that? Because we in a very experiential way, done quite a lot of finding out that clinicians don't like to talk about breathlessness. Yep. They feel hopeless.
Yes.
Isn't it interesting we use the word dyspnea, which I haven't
Yes.
ever heard a patient use?
No.
And it feels like that's the psychological thing to separate it.
And you'll notice that the syndrome very clearly came. I tell you, we had a big row with the Americans over that. They wanted dyspnea. They're wedded to, and I apologise for any Americans amongst you, but I'm afraid we've shouted you down. Yes.
So is there work being done to understand why clinicians feel hopeless and don't raise it? So those 25% who present in A&E with COPD, how often will a class intake present with cough? Because it's easier for the clinician to answer cough.
Well, interesting you should say that. So Anne's survey, which was self-report, for those who gave permission for her to look in their clinical record, she squirreled away through the clinical record, and in only 67% was there anything remotely related to breathlessness in the clinical record. It was chest pain, it was, I think, ill was her favourite. Her second favourite was the patient with a respiratory rate of 44, where there was no mention of anything to do with breathlessness. Now, the other interesting thing, we're just, one of the criticisms of the chronic breathlessness syndrome work is that we had no voices from lower middle-income countries. So we now are just about to submit a paper of 3 focus groups from South India, pulmonologists, they call them pulmonologists, so I've had to learn how to speak that, cardiology, medical, clinical, hematological, oncology, and a couple of brave palliative voices. And we have on tape things like, it's distressing to everybody. We are really upset when we see this, and so therefore we ignore it. Because we don't know what to do about it, we think our treatments don't help. And here's the thing that I hadn't anticipated, the oncologists feel guilty because they think their treatments have caused it. And they then say, well, and there's nothing, we can't measure it, and that's in fact not true. There was a little bit of a voice of saying, oh yes, I think maybe palliative care might be helpful, but we can't refer because they're too busy and we don't do this. And there's almost like every glimmer, there's a barrier. But it comes down to because let's face it, and the clinicians, we came into this business because we care for people. And so of course it's going to hurt when we see somebody that we feel we should help and we feel that we can't. So I get that completely, that we have it on tape. It's the distress that it engenders then, triggers, ignore it, and we even have one who in anger said, and I think they're a pain in the backside, the worst side effect, because it made them feel so bad, it comes out as attack rather than just crawling into a corner and ignoring it. They thought the syndrome would be a great idea because they said, if we've got something we know what we've got a structure to look for, and we've got it embedded into clinical pathways that we feel we can do something about it, we will look for it. But while people think they don't know about the evidence base, why they don't have local services that they can say, go and see this, that, and the other, we will not see it. And then we hide behind, well, if it's important, the patient will tell us. Really? Don't think so. Which of us, I go to my GP, I'm rehearsing in the waiting room. And I get there and 5 things fly out my head and I think, well, I'm only allowed the one. If I do that and I am health literate and I can advocate pretty well for myself on still, I'll have you know. If I go to pieces in the GP surgery, what about our poor patients who do not have that self-advocacy? We have to take that responsibility. So yes, you can, and if you can capture some of those voices, capture it, write it up and publish it.
That should be the last question.
Is it any relationship between breathlessness, ethnicity and background? And what about children?
So children I can't tell you about just yet, but that's one of our next things to look at. Ethnicity, there's differences around the world. I can't tell you about within the UK, but certainly there is an amazing Korean study where an enormously high prevalence of breathlessness. We want to do some work in India and Nepal, where in Nepal obviously you've got altitude as well, but you've got things like open fire solid fuel cooking. Women, enormous high rates of COPD with women. The government subsidy, they're trying to move it, but the alternative fuels are so much more expensive. And many households cannot afford to get out of that vicious cycle of cooking, having to put food on the table, and at the same time your lungs are being shot to bits. And in the cities you've got pollution. So absolutely there are variations around the world.
What do we do with climate change?
I'm sure it's not going to make the pollution any better. No. Well, that's cheered you all up, isn't it?
So I think we should say we've finished questions, but very welcome to ask your interesting lawyers. So please let me just thank you again.
You're very welcome.